Hello guys, so today I did thoracotomy. Thoracotomy, it was for esophageectomy and gastrectomy because of cancer. So I just felt I need to do some notes for you guys, because sometimes if you hear of thoracotomy, you just feel, oh, I don't know. So when we are doing thoracotomy, the patient will be on the left, depending with what they want to achieve. In this case, they wanted to remove the esophagus. So the patient was on the left lateral side, and the thoracic bridge of the operation table was raised. So the patient will be in his left lateral, but the chest part will be raised. So the right arm will be resting on the arm support, the left arm was on the arm board, and there are a lot of strappings which are, they are like straps which secure the patient from falling. Basically vanoti tanga vari kusungira munhu pamubhedha kumakumbo, pawaist, and then my shoulders, they don't have to do that because this arm support prevents patient from falling. So they clean the drape, they does an incision from almost from the back into the ribs, going towards the anterior part of the chest. Okay, and then they gain access, they go through in between the ribs, and then they will gain access into the lungs, and then they retract the lungs and they will start to operate on the esophagus, removing the esophagus. Right, so us as nurses, post-operatively, it depends with the hours you are asked to nurse the patient. But immediately when this patient comes from theater, we want to manage pain, and we also want to manage drainage, because there's a high risk of this patient dying from fluid loss. Mainly bleeding is so crucial. So just a tip, if you are asked post-op management of a surgical case, you have to assess where these people were working. If they were nearer to the vital organs like the heart, like the lungs, and they've been cutting something, especially in the abdomen, chest, if you are asked a question to nurse this patient the first 48 hours, please, first thing is pain and fluid volume deficit. This patient, we can lose here. If he bleeds, we can lose this patient. So for example, patient, we lost almost 5 liters when we're doing this case. We lost 4.6 mils or 4,600 mils of blood. So it's a huge loss which needs to be taken care of. Okay, so pain management post-operatively, this pain is related to surgical intervention, which means incisions, positions, as evidenced by a patient. Maybe the heart rate increases, patient restless, those are the indications of pain. So there's something called epidural catheter. Epidural catheter, it's a catheter which is put, which anesthetists put in the patient and left it there, so that post-operatively analgesia, like a pain relieving medication, can be given through that catheter. So this catheter is put in the thoracic epidural, and then local anesthetics. Remember, spinal pain prevention, it will be more of regional. It is better because it doesn't promote addiction from things like morphine, things like Marcaine, bupivacaine. They are local anesthetics, which means they just numb the area which we want to relieve pain. So epidural catheter, it is a catheter inserted in the epidural to block nerves, to numb the nerves which supply a specific area. So in this case, they put this epidural catheter in the thoracic so that we numb the thoracic nerves that supply the part which was operated. So us as nurses, as we care for the patient, we need to make sure this catheter remains in situ. Even when you are turning, you carefully turn the patient to prevent this catheter from slipping off. And this patient, mainly most of them, they go to intensive care unit, or patient is nursed in air mattress to relieve pressure on the incision line, to reduce, which relieves, if pressure is reduced, it means pain is also reduced. Prescribed medication, depending on the country where you are. In Zimbabwe, follow your ADLIS, and then check equipment if it's working properly. For example, pumps, make sure they are charged, cleaned, and working properly, because some of the analgesics, especially given by epidural catheters, they put them on fluid pumps, through fluid pumps, for continuous administration of pain medication. Then check drains every 5 minutes if they are kinked or blocked, because blockage of drains increases pressure in the wound and worsen pain. And then patient is nursed in a calm, whatever the usual thing which you do, and then assist patient to be in the most comfortable position, and check any swellings, and also always make sure you if you're not sure of what you are doing, always ask for assistance from a senior member of staff or a trained someone, especially when you are dealing with things like fluid pumps. And also, this patient, he had drains, so we also check on drain sites if there is any swelling. We also check on the feeding tube, around the feeding tube. Sometimes pain might emanate from those sites without knowing. If they are inflamed or there's infection, the pain can be aggravated. Okay, then we go on to fluid volume deficit. Please, I think you have heard me several times. When patient is coming from theatre, please don't jump to go and write an intervention like anxiety. No, when patient is coming from theatre, fluid volume deficit followed by pain are the priority nursing diagnoses. So fluid volume deficit, vital signs, always check vital signs, is baseline data, check drainage amount from the underwater cell drain. If it's more than, I can't remember how many per minute you need, it's an indication of excessive blood loss. If there is excessive blood loss, inform the surgeon straight away so that patient can be helped immediately. Then check dressings every 5 minutes, and first 30 minutes, then 15 minutes hourly, and then hourly in case the patient might bleed from the operation side. Prescribed volume expanders, that one you know. Check blood before giving. You need to check the patient's name, blood group, hospital number. Make sure we are giving correct blood to improve their blood circulation. Urine intake and output to be measured, documented and monitored, since urine less than 2 ml per liter may indicate fluid volume deficit. We also put flotrons, flotron pump and flotron boots. It is a method which is used in patients who can mobilize immobile patients. So basically flotrons anoita pump blood, anoita kunge ngati chiko, let's say zvibhutsu zvinoputira kaufu yese mupimbira, handiti kaufu mupimbira, tingangoti their size togona kungomaita masaizi emapulling socks, mabeloni, mani hayaya, but iwo tunenge turi tubhutsu twamunorepa. You wrap the cuffs, and then tunenge tuine it has a connection which goes to the machine. So machine unocreate unopampa like zvinoita BP machine, release pump release pump release. So zvinopa inenge ichipampa in such a way that blood harigare calves. Blood is constantly pumped from the lower limbs back into the circulation. So when you are writing your intervention, you can add that flotron pumps, as a nurse you have to put make sure the patient have flotron boots and the pump is working correctly, so that these flotrons, they pump blood from the lower limbs, improving blood circulating the circulatory volume. So basically these flotrons, they will put the calf muscles in motion. They will actually be alternating like munhu ari kutofamba, making sure blood is squeezed. But when we are walking, the muscles of our legs pushes blood back into the circulation. So these flotrons, they prevent blood from staying in the from blood stasis. Hopefully you understand it. If you don't understand it, please go online and just write flotrons. They will come out. You will see what I mean. The spelling is, yes, it's FLOWTRONS, flotrons. Then prescribed anticoagulants. If this patients who have done this, patients who have gone through thoracotomy, they usually anticoagulants are prescribed. I'm not sure there, but here they prescribe anticoagulants. I'm not sure, they may be tapering or what. You need to check with what happens in Zimbabwe, which anticoagulants can be given post-surgery. These anticoagulants that are very important. They prevent blood clotting. If a blood clots, the vessels get blocked, reducing blood flow back to the circulation, reducing circulation volume. At the same time, clots are a critical complication which can lead to death after such surgery. And then remember, we have removed the esophagus. This patient definitely will have a feeding tube which goes directly into the stomach. So after the removal of the esophagus, they seal the opening into the stomach. They seal it and then create another opening through the upper abdomen into the stomach. So there is a tube which we use to feed the patient. It means the patient will be getting feeds from the tube directly into the stomach. Okay, so depending with the hours which you are asked to nurse this patient, if they don't give you a time frame, go on to talk about gastric feeding. Give fluids through the gastric feeding. Don't, now you are not nursing the patient giving them oral fluids. No, you give them through the gastric tube, the gastric feeding tube. So those are the things to think about when you are given such a case. I'll continue to give you some hints, and then these few interventions, hopefully they will help you to add on what you have so that you maximize and you pass your exams. I wish you well. Thank you. Bye.